have representatives from KPMG here tonight. Thank you for being here. We have a distinguished Chief of Staff from the Mayor's office here tonight. And I appreciate everybody being here. First, we have an opportunity for each member to disclose if they have any conflict of interest in any matter that's coming before the board tonight. Give you the opportunity to recuse yourself, if so. Okay, if not, thank you. And I will now ask Dr. Bullock to read our mission statement and vision for the hospital.
Thank you. Our mission statement: to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice. Our vision here at NGH is to be a leader in exceptional community health care, one neighbor at a time.
Thank you, Dr. Bullock. Next, we have opportunity for public comment. Do we have anyone registered?
There are no requests.
Thank you. Okay. Minutes have been distributed for all to read. Dr. Nettles, do you have any comments on the minutes?
I've reviewed them, and the content I'd like to present them to be accepted, please.
Okay. We have a motion to accept the minutes of the last meeting in May. Do I hear a second?
Second.
Any discussion? All in favor? Aye. All opposed? Motion passes. Thank you. Under old business, we have a report from the PSA work with Meharry. Mr. Escobar.
Thank you, Mr. Chair. I'm very pleased to report that as of this afternoon, a signature-ready version of the PSA has been circulated among people at Meharry and at the hospital. The final version of the PSA has been negotiated. It has been reviewed by counsel at Meharry and outside counsel for the hospital, and would appear to be ready for signature. And yeah, I think it's appropriate to commemorate. The term of the PSA will run from July 1, 2025 through the end of the calendar year 2027. That is set to coincide with the lease agreement, the extension to the lease agreement that we have with Meharry for the hospital. And then subject to consideration after that. The board is aware, but I will just reiterate what a remarkable job our leadership team did. It was my privilege to sit in on those meetings with Meharry, and it really was the entire leadership team that was involved. And for an agreement that had lapsed and was the result of a significant amount of work to try to renew over the last several years, this team put this together in a matter of months. There were discussions that had to be undertaken about points of disagreement that were resolved in a really good way, in a productive way, resulting in this agreement. And it's just, it's a really amazing accomplishment. I would say, Mr. Chair, at some point soon, we were asked by Metro Legal to make sure that this was an agreement that was put in place, and soon we'll be able to report that it is in place.
Well, that's a great accomplishment, and I assume it will be coming before this board in July for approval?
I might ask Ms. Lewis or Dr. Blackledge, or whether that is, or others. I know that Dr. Elders is not here tonight, but so I actually don't know if it requires board approval or not. I assume so.
It's my understanding that it should come to the board. We do need to make sure that the board is aware and apprised of to what the hospital is being bound to. So once that is signed, it will be submitted. Our goal, as we've stated, is that we will have that at the next board meeting. If there is any change to that, of course, we will alert the board as soon as possible.
Yeah, I mean, it seems essential to me that the board approve this agreement.
Absolutely, it will be
provided. I just
provided.
assume that would be so.
Yes, it will be
Derek?
provided. Yes.
Thank you, guys.
I am of the opinion it will require this board's approval. I also need a moment after this meeting to do research as to what requirements it may hold within Metro too. Since Metro created this hospital authority, I'll have to check to see if that agreement requires any Metro sign off as well. So I'll have that answer before your July meeting.
Thank you. Okay. Next, Dr. Bullock, our Chief Medical Officer, with a report from the medical staff and the bylaws status.
Thank you. Much like the PSA, we are making amazing progress with the bylaws. Just a lot of good communication, good effort, conversation. We are planning on having hopefully a final draft by the end of July, early August, to go to our annual medical staff in August for full approval and sign off. So we continue to meet every Monday afternoon and with good participation and good progress.
Thank you. And likewise, if I'm not mistaken, that also will require board approval. Thank you. Dr. Miller, credentials report.
There was a credential meeting last week, and there were 3 people who are being put forward for initial appointment. Dr. Bricknell, who will be in general medicine, internal medicine and general cardiology. The second is a Dr. Johnson, who is a general surgeon, also has bariatric experience. Dr. Stone, who will be in internal medicine and neurology. There were 2 resignations. One is a Dr. Humes in emergency medicine, and Dr. Drummond in psychiatry, who moved on to a new position.
Dr. Bullock, is Dr. Johnson the new chief of surgery at Meharry?
Yes, she is.
Yes. Okay. Thank you. All right. This report we take as a motion for approval from the medical staff committee. Do I hear a second?
Second.
Any discussion? All in favor? Aye. All opposed? Thank you. Motion passes, and thank you, Dr. Miller, for becoming involved with that. Quality report, Ms. Lewis.
Hi, good evening, everyone. I'm Felicia Denson, the Director of Quality and Patient Safety. I'll be doing the quality report for today. In your package, you'll see the verbiage around our quality report, and I did reformat this to try to extend it where we can have an open discussion and some updates around where we stand with things that we're doing well and things that we have improvements to make as well. Do know that this quality report does focus on metrics that are primarily reported under Leapfrog and CMS. Some of them do overlap, but we do this because we feel that they are relevant in order to be able to provide high quality patient care, and it enables us to be able to have national benchmarking too as well. Our goal is to make sure that we keep our hospital authority board informed, as well as our medical staff and executive leadership, and so that we can ensure that we're accurately reflecting how we're providing care and identify opportunities to improve. This summary does encompass mostly our May 2025 data, and we do have an update where we have successfully validated our Thunder report to be able to start again this month reporting goal number 3, which is around our severe sepsis and our C-section rates. So I'll cover that as well. That data will be through April of 2025, though, instead of May. So going on to goal number 1, which is our safety of care metric. For falls with injury, we did in the month of May with no events, so we're doing excellent there. But as an organization, we do continue with our action plan around overall falls prevention, because the best way we can prevent a fall with injury is to have no falls at all. So we do have a very robust falls prevention committee that meets monthly. The objective of this committee is to monitor overall bundle audit results that are dealing with falls. We have since instituted over the last couple of months an expectation with our nursing leaders where they will proactively go and audit a certain percentage of all patients that are moderate or high fall risk and make sure all of those safety metrics are in place, and we're seeing excellent results from that. Hence, our falls are going down. Also, anytime we have had a fall event, we do what we call a deep dive analysis, where we look retrospectively to see what we could have done differently to prevent that fall. Those results are in turn shared with all of our nursing leadership team. We are expanding that group to include rehab and some other ancillary support teams, because there's more than just our nursing staff that work with our patients. We want to make sure we get engagement from all partners. On to hand hygiene. There are two metrics that are on there. The first one is our overall hand hygiene compliance goal. Our target is to be at 100%, but our compliance goal right now is at 95%, and we will continue to increase that incrementally each year. The goal of this metric is to evaluate whether or not staff are actually doing hand hygiene before going into a room and after leaving a room. Unfortunately, for the month of April, we did go down, for May, we did go down to 93%, so we did not meet that mark. Our action plan to be able to increase compliance is to continue to empower all of our observers, as well as anyone in the organization. If you notice someone not doing hand hygiene, that you coach in the moment. Do not miss the opportunity that if you see someone not doing it, that we don't coach them. We want them to be coached and understand the importance of hand hygiene. We do have a new infection prevention support organization that is reinvigorating our hand hygiene surveillance program to try to extend our observations to some of our nurses and others who are on the clinical ladder program, to incentivize them as well to be observers and also to coaches. The next hand hygiene metric is around our leapfrog goal, and this is strictly the number of observations we have per unit. Leapfrog requires that based upon the census of the unit that we have to have X number of observations for all of our nursing units, and we have gone 18 consecutive months of meeting that goal for leapfrog. Effective July 1st, we will have a slight adjustment to this, because as our census changes, every year Leapfrog asks us to reevaluate, and we adjust our goals based upon that. So you might notice that the goal will go up starting with the July report out. For our barcode medication administration, that's the BCMA compliance, we have yet again exceeded the goal of 95%, where we've gone 2 consecutive months with increasing that adherence rate. And we ended May with 97%, which we were very excited to see. This metric severely decreases the likelihood of medication errors, so we're very excited that our staff are being more consistent with scanning meds to make sure we're giving meds to the right patient in the right route and the right dose. But we do have an action plan, because we want to make sure we continue with that forward movement. We are sharing data consistently with all of our unit leaders to ensure that we are continuing to counsel staff who consistently might have avoided BCMA barcode scanning. But also, too, we're having conversations where if it's an issue around technology or equipment accessibility, Wi-Fi, we are escalating those items and resolve them so we can continue to have greater than 95% and hopefully 100% compliance there. Our second area is quality of care. These are our healthcare acquired infections. And for the month of May, we, out of seven out of 7 metrics, we finished with no events there. But I did have one update, because we did come across one C. diff infection event for the month of April. This was a delayed reporting due to some issues with reports that we're utilizing. We are working through that barrier now as we speak. That C. diff event took place in April, as I shared, and we had gone about 615 days without a C. diff event, which is huge. But with every event, we take it extremely seriously, and we did a deep dive into this event with our nursing staff, We had a discussion with our med-surg physician leaders on today about it. Pharmacy has been involved, the laboratory, and our environmental services team members. Some things that we have identified that we're going to work on as an organization: make sure that we're improving documentation of stool consistency, because we found with this event, the patient was more than likely colonized and didn't qualify for testing, but we want to make sure that all of our care team members are aware of those clinical practice guidelines. Also, our pharmacy team is committed to addressing antimicrobial stewardship opportunities, because with this particular patient, the patient was on PPI therapy for an extended period of time, which can increase the risk of C. diff infection. And there were some questions around the longevity of some of the antimicrobials that this patient was on. Also, we have confirmed that our laboratory continues to reject stools that do not meet the criteria. And we're in the process of developing a testing algorithm to have a nurse-driven protocol to screen all C. diff testing orders to make sure that they meet the criteria for testing, and an escalation pathway to be able to have conversations with our providers when the patient does not meet the clinical practice guidelines. Onward, we have gone over 365 days without a CLABSI, CAUTI, MRSA bacteremia, or surgical site infection, colon, or hyst event. So we continue to have great outcomes with those. I'm going to pause and see if there are any questions. I know that was a lot of information, but that's covering section 1 and 2 of the dashboard. Any questions? Okay, we'll move right along. Okay, under goal number 3, timely and effective care. For our severe sepsis goal, this is the metric where we monitor our bundle compliance and how effectively we follow through on meeting those measures. Our goal is 58%, which is the national average for meeting the severe sepsis goal. And I'm happy to report that for the month of April, we finished with 72.7%. We have not met that goal in 11 months. So we were extremely impressed to see that outcome, but it didn't happen haphazardly. There was a lot of work that went into that. One of the things that we've been doing is anytime we've had a fallout with the severe sepsis bundle, we have a work group that encompasses nurses, physicians, pharmacy, quality, infection prevention. And we have found that a lot of our fallouts were around blood culture collection, and making sure that we were collecting blood cultures prior to antibiotics being started to avoid false negative blood cultures, and also too around IV fluid administration. And being able to work with our ED partners and ensuring that they had access to timely blood culture collections, and then making sure that our staff understood the pathways for IV fluids, we've been able to move the needle there. So happy to see that outcome. For our C-section birth rate, we did not meet our target there for the month of April. Our goal is 24.7%, and we were at 27.3%, missing the target by a couple of percentage points, but this was a pretty significant decrease compared to the month of March. One of the things that we have found, and we've been in discussion with our women's health services, is that in documenting the justification for a C-section, we have opportunities in the medical record to make sure that we're evaluating the reasons for C-sections and to make sure that they're truly meeting the clinical picture of the patient. We have discussed this, like I said, with our women's health services. We're going to get in front of our OB team as well as our pediatric team. They have all of the codes now. We're going over case by case where we've had these fallouts, because very likely the reason why this rate might be higher than it needs to be is not necessarily understanding the codes and how they correlate with exclusions that are allowed for this metric. But more work to come on there. Under goal 4, this is our patient satisfaction, patient-centered goal. We did increase our inpatient response rate by about 14% from April to May, where we went from 17 return surveys to the organization up to 21. I know that seems like a minute increase. I'm looking at Mr. Lesser because we talked about this a lot. But we have noticed a decrease in the number of surveys that are returned because of issues with the mailing address. So we're hoping that as we move the needle there and more surveys are getting to our patients, that this score will continue to increase. But do note, compared to first quarter this year, we have gone up about 60% in overall surveys comparing first quarter to second quarter. So we are moving in the right direction there. For inpatient satisfaction, these are the questions that are asked of patients. And in order for us to have the full points or percentage rate, you have to be rated as a 5 to get that. And we met our goal for 3 of the 4 questions that we measure. For responsiveness of staff, we increased from 55% in April to 69.7% in May. For cleanliness of the hospital, we increased from 66.7% in April to 81% in May. And quietness of hospital, we increased from 55.6% in April to 81% in May. Willingness to recommend, unfortunately, we did go down there. We were at 57.1%. That goal was not met. One of the things that Kathy Poole has been working on diligently, along with the marketing team and our patient experience team, is addressing issues around making sure that our staff members are engaged from the point of new hire orientation, because we do have an opportunity to get in front of them and talk about patient experience and the satisfaction survey that is sent to them. Making sure that we develop a culture and ensuring that we're responding to the call lights in a timely manner, because that has been a repeated issue we've noted on some of our surveys that could impact that willingness to recommend. Also, a lot of the cosmetic upgrades that are taking place in the organization so that the building can look more visually appealing to our patients, and working through that with our facility staff as well as Mark Brown and his team. Also, we are committed to expanding reporting of our patient satisfaction scores. So you'll notice starting in August that we will be adding the emergency department, our ambulatory surgery services, and our ambulatory clinics to the patient satisfaction dashboard, so that you can see how we're performing in those areas too across the organization. Currently, we've only been reporting inpatient scores, but we feel that it's necessary to be able to show the full picture of the organization going forward. Goal 5, culture of safety. As you can see from the signs that are in our elevators now, our employee engagement survey comes out in July. Once that survey comes out, we do have questions around the culture of safety embedded within it. And so we'll be able to give an update late summer to early fall on that. And then for Goal 6, regulatory, we did have 2 unannounced surveys in May from the Tennessee Department of Health. One was our ED pediatric survey assessment. This is a standing survey that they do routinely. We had one finding, and this finding we were not surprised, because we did get rid of our helipad. Because as an organization, we do utilize Vanderbilt as our comprehensive pediatric center, and we're only 2.3 miles away from Vandy, and we didn't feel that helicopter service would expedite a transport rather than ground. Well, the Tennessee Department of Health still has the rule that you must have access. And so our emergency department, as well as Dr. Bullock, worked with the Metro Fire Department to give us a landing space that's pretty close to the Fisk campus, that if we had to utilize the service, we at least now have it available. So we were able to clear that finding. So in that, we have expanded airlift services as an organization. And our other survey was 3 complaints that we had, and we are awaiting the final report for that. So I'll have an update next month. Any questions? Yes, sir.
Just a reminder of what we have talked about before. You mentioned on the severe sepsis, the 58% is the national goal.
Yes, sir.
That we always try to exceed and have goals that are greater than the national goals.
Yes, sir.
So that 58%, if that's the national goal, I would hope in successive or new references, that number would be higher, because if we're going to be exceptional, we're not going to be average.
I agree. And what we'll end up doing is, since we're ending the fiscal year at the end of this month, and all of the CMS metrics normally come out around July or August, we will look at the national benchmark, and now that we're at 72%, the needle will be moved. You're welcome.
I'd just like to comment, this is a very encouraging report. We've seen a lot of activity over the last year, a lot of improvement. We had one case of C. diff, and those of you who are not in clinical medicine, we used to have many cases in the hospital all the time, and to have one case after all these months is terrific. The the catheter-related infections, both intravenous and urinary, being zero. It's just, we just don't see this in other hospitals. So congratulations to the quality staff and Dr. Bullock, the entire medical staff, because it takes all those folks and the nursing staff particularly to make this happen. So thank you very much for this good report, which does require approval. Do I hear a motion?
I make the so move.
Second.
Okay, second. Any discussion about the quality report other than what we've heard? All in favor? Aye. All opposed? No. Motion passes. We will move on to the nominating committee. We heard the nominating committee report last month and approved it, but I would ask Dr. Miller to give us the highlights and results and to conduct an annual election of officers for us.
So the nominating committee has recommended the slate of Christy Smith for Hospital Authority Board Chair, David Escobar as Hospital Authority Board Vice Chair, and Dr. Ari Nettles as Hospital Authority Board Secretary. So those are the three recommendations from the committee, and I would be open to anyone who would like to add additional people for nomination to any of those three positions. For chair, vice chair, and secretary. If not, this will be the slate we put forward. I don't know if we really need to do a paper ballot, do we? Okay, so if you would fill out your paper ballot and pass it down to Janet.
I'll come around and pick it up.
And Janet, would you read out the individual votes, please?
Yes, and Dr. Nettles is going to tally as I read.
Okay.
Okay. Dr. Martin voted for Christy Smith as chairman, David Esquivel as vice chairman, and Dr. Nettles as secretary. Christy Smith voted for Christy Smith as chairman, David Esquivel for vice chairman, and Dr. Nettles for secretary. Mr. Lesser voted for Christy Smith as chairman, David Esquivel vice chairman, and Dr. Nettles for secretary. Dr. Enzarue voted for Christy Smith as chairman, David Esquivel as vice chairman, and Dr. Nettles for secretary. Mr. Esquivel voted Christy Smith for chairman, David Esquivel for vice chairman, and Dr. Nettles for secretary. Dr. Fisher voted Christy Smith chairman, David Esquivel for vice chairman, and Dr. Nettles for secretary. Dr. Nettles voted Christy Smith for chairman, David Esquivel for vice chairman, and Dr. Nettles for secretary. Dr. Miller voted Christy Smith for chairman, David Esquivel for vice chairman, and Dr. Nettles for secretary. That concludes the votes.
Dr. Nettles, you need any help in tabulating the results?
Gosh, yeah. It was unanimous for everyone. So 8 for Christy Smith, 8 for David Esquivel and 8 for Dr. Nettles.
So we've met the required threshold of 6 votes. Congratulations to the new officers to take over with the new fiscal year, which is coming up in a few days. Congratulations.
Mr. Chair, if I could make a comment. This has been a year of challenges for the board and for the hospital, and I would like to thank the current officers for all that they have done to get us to a better place.
Thank you. Thank you, Dr. Miller. It's been exciting. We'll talk about that some at the end. We'll move on to the CEO Performance Review Committee report. Ms. Smith.
Thank you very much. Our CEO Annual Performance Committee met with the goal of trying to be on track for a July finalized version of the assessment form by which the CEO is analyzed for a bonus opportunity up to 5%. In the past, for those of you who haven't been here, we have been, the committee has been behind in this analysis. And so our aggressive goal was to not only get caught up, but to going forward set a precedent for being on time. And that's the fairest way that we can give the sitting CEO the opportunity to look at these goals, review these goals, and then obviously execute successfully on these goals. So that being said, we are almost there. We hope to have you a finalized version by our July board meeting. We have I would call it a almost finalized draft. We had a great meeting with some weigh-in by not just our committee members, but also Dr. Veronica Elders, who is our interim CEO. The next step, also, I've reached out to Dr. Blackledge, and she and I are going to be sitting down to review the financial metrics to make sure they're in alignment with the terminology that's specific to Nashville General, and make sure that the goals are achievable, but also, quite frankly, a stretch in some areas. And so we want to just be thoughtful about where we are in the process. We also wanted to make note, and I just remind everyone here that we are in the process of doing a financial analysis with KPMG, which you'll hear about later. So I think the goal longer term would be, you may see some of these performance metrics come out that are very applicable to 2026. The goal would be to continue to push our committee and those who serve on that committee to come up with more, some qualitative metrics, but very specific quantitative metrics that allow for not just a pass or fail, but quite frankly, reaching different levels. So more to come on that, but excited as we move forward with this specific form and most importantly, the timely delivery. So that's it.
Thank you, Ms. Smith, and we look forward to having the committee's recommendations circulated prior to the July meeting so that we can approve them and move on. Next, the CEO Search Committee report. Mr. Esquivel.
Thank you, Mr. Chair. The board will recall that in order to conduct the CEO search, the board and committee decided it would be very beneficial to have an executive search firm, an external firm, assist the committee in its work to conduct a nationwide search for our hospital's next CEO. Part of that search will include determining and getting feedback from both sources of people internal to the hospital and external stakeholders for the qualities and that we're looking for and need in a new CEO. So in order to hire a search firm as a public body, we have to conduct a solicitation, a public procurement, and invite all people who are interested in bidding on that search firm contract to make submissions. The request for proposals for that search firm was issued on Monday, We're grateful to Metro Government Procurement, which has been working with us and is running that process with the hospital, but appreciate Metro Procurement's help with that. The deadline for submissions is July 24. So all of the search firms who are interested in bidding on this will have their submissions done by July 24. At that point, an evaluation committee will review the submissions, score them, prepare a slate of groups to be interviewed and have some dialogue. And at the end of that process, the evaluation committee will recommend first to the committee and then to the CEO search committee and then to this board a firm to hire to conduct that search. I should also say that the RFP is broader than just the CEO search. There are other occasions when the hospital is hiring for executive level positions where it's useful to have a third party search firm. So whichever firm is selected through this process will conduct the CEO search, but will also be available to the hospital for use in any subsequent executive level searches. The overall timeline for that process from the opening of submissions from bidders on July 24th until we will have go through the process of evaluation and select a firm and contract with a firm is probably 3 months or so from that point. So I think that we can anticipate in September or so having a firm and beginning at that point the actual process of going through the CEO search.
So to clarify, our goal would be for the board to approve the recommendation of a CEO search firm in September.
That is the bottom line. We should be beginning that CEO search in earnest in September, I would estimate.
Any questions for Mr. Escobar? Thank you for your hard work on this challenging project. Next, Finance Committee report, Dr. Blackledge and staff.
Good afternoon. I respectfully come before you to share the budget for FY 2026 as we prepare to move into the new year. We've covered the mission, and this is why we exist, through Dr. Bullock, and then previously in Finance Committee through Dr. Nettles, so we'll move forward. To the left side, and there should be a snippet in your packet as well, but to the left side, we presented early on to Metro the budget for FY 2026. I think the first preliminary was submitted in February of 2025. To move forward, we received a modification, and so based upon receiving that modification, we have revised our budget in-house, and that is labeled with the green header. And so I'll talk about some of those key variances. To start, when we look at our patient revenue, we did increase our patient revenue by 5.1 million and or 2%, is what we looked at, and what that did result to as it relates to our net revenue was 1.1 million. So that increased 1.1 million, and that was 2%. I want to talk a little bit about the city supplement, as that is halfway the page. From our initial submission, we submitted $66 million with the revision at 60.7 million, and really just kind of point out that led to our modification of some of the other numbers to make sure that we have a good budget and a good plan to support achieving the budget. And so what that did for our total revenue is decreased that amount by about 4 million. When we dropped down to our salaries and benefits, we had some addition here, in total about 1.4 million. When we looked at our other expenses, we decreased some of our supplies and some of our pharmacy items, and so that resulted in about 3.5 million. So what does that look like at the end of the day? At the end of the day, our total expenses decreased by 2 million. At the end of the day, the operating margin that we submitted with our preliminary budget was reduced by about 2 million. And so there we have the key variances that align with the changes that we made within our budget. And so one of the things that we did from there is we laid out a plan to begin to look at how we're going to achieve this budget, how we're going to have some regular cadence, and how we're going to communicate that throughout our house. And so I'll pause right there to see if there are any questions. Otherwise, I'll move to the next slide.
I had a question about
Sure.
the dish payment
Yes.
of 1.6 million. Is that based on history? Is there a chance that that would be higher, lower, or not at all?
Well, we haven't, so to back up and share a little bit, dish payments are based on funding provided to hospitals that really basically see a significant amount of what I would call uncompensated care or low-income patients. So that has not changed within our organization. We're not seeing an increase or a decrease in the number of low-income patients. So we anticipated that would stay around the same.
And is that have any, is that determined by the federal government at all, or is that all by the state?
I'm not sure. I believe the federal government. I'm not sure right now which one, but I do know that it's funds to help subsidize those that take care of a larger population of low income. And so my response to that is going to be federal, but I don't have the regs right in front of me.
Yeah.
Can I ask about the additional state funding? That's a significant issue in the current budget, where I think there's sort of around a $10 million difference between what we anticipated and what it seems we've received, at least so far. How is that addressed in the new budget? And how confident are we going into 2026 that what we are projecting for state revenue is actually going to be state revenue we receive?
Right. So one, we have made phone calls. We've did follow-up. We've gathered all the documentation that we could receive on that piece of it. So that's number one. We did a little bit of investigation and research. Two, we did not budget the $10 million that was in question in the upcoming year. So that's that part of it. Yeah. And we have a confirmation in. This is federal. So thank you. Appreciate that comment. So we were right. This is federal. With that piece, I probably can go back or go to the next slide, which really our total sources of income is really 159.9. Disregard, we had another million, 1.1 that we added through the net revenue based on the changes that you saw on the previous slide. But I am respectfully requesting approval of our budget with the modifications made for this upcoming year, which starts in the next few days. You can go back.
Can I ask about the net patient revenue? And I know that it's within the materials, but if you could just point me to, how does the net patient revenue of $67.4 million compare to where we anticipate net patient revenue to end at the end of this fiscal year?
So at the end of this fiscal year, and I don't have it in front of me, but we anticipate about $62 million. So that's about 62. And the way that compares is when we look at the current year, we had 2 months that were anomalies. Our monthly average has been about 5.3 million, somewhere between 5 million and 5.3. We had 2 months that were anomalies. Those months were February and March, or January and February, but it was basically the result of the Cerner Go Live and the slowdown related to that, and then it was a Medicare bad debt issue. Yeah. And then this upcoming year, we need to collect 5.6 to achieve the new target, which is 68.5 actually. It's listed on the other one, if you go back to it.
This is a question that came up in a committee meeting this week. I remember hearing that the Cerner Go Live was affecting patient volume because of the transition. Can we anticipate that the move to the Cerner system is going to result in some efficiency or increase in ability to see patients? In other words, is this just a loss to us, or is the implementation of Cerner expected to be additive to net patient revenue because we're putting in place a system that is going to improve? And is that accounted for in the budget?
Go back 2 slides. Right there. Right, so when we look at this, Cerner, we should actually be able to leverage efficiencies through Cerner. Yeah, through Cerner. Cerner, we should be able to leverage efficiency through Cerner. So one of the items that we have is we must grow our patient revenue, right? And so some of that is marketing that we have to do within our organization. Some of that is removing barriers, internal barriers and challenges that we have within our organization. There are a couple of items that we've identified, and we didn't go through it totally, but in our plan, we have 10 key objectives. Those 10 key objectives are literally there, and we're going to hardwire the monitoring and measuring of those, but that is designed to promote growth within our organization. So that is part of the plan. Cerner is the foundation to help support that. What you are speaking to should have been a one point in time. And that time was when we had the low cash performance months. And if you take those or remove those 2 months, I do believe it was January and February, we remove those 2 months, then you've been averaging around 5 point some odd million. We need to collect 5.6 moving forward. So we need to get X amount of patients in addition to what we have today. And then there are key objectives. There are 10 of those that we've listed out. I think 8 are related to patient volume and patient growth. And there was some degradation as it relates to our reputation that we have to address as well. And so we have to deploy the right marketing strategies. We have to write, I think I heard Ray, will introduce Ray a little bit later, but when we talk about, our workforce, and reshaping our workforce to execute on the needs of the organization that support our mission. I respectfully am asking for a budget note. I want to make sure we don't lose sight of that too.
We are tasked with approving this amended budget.
Move to approve.
Second.
Any discussion? Thank you. All in favor indicate by saying aye.
Aye.
Opposed? No. Thank you. The motion passes.
Thank you, Board. I do want to bring up KPMG. I think we've heard before. They're here as they're walking to the podium. I will share that I took this role in February, and after 30 days and a quick assessment, recognized the need for additional support and had multiple conversations. And thank you, KPMG, for joining us.
Good afternoon, everyone. Appreciate your time and having us here. My name is Hillary Simic. I'm a partner with KPMG and really responsible for the overall strategy and approach to this accounting and financial reporting improvements project. I have Chris with me today, and I'll let him introduce himself when he stands up to the mic. But really, we just wanted to give you guys an update. If we want to go to the next slide, a quick summary of our timeline. You guys kind of know where you've been. We started in earnest in June. So we have from May to June, we started with our contracting, and then we really kicked off beginning of June to start our process. What we really are focusing on is how to improve the process around the accounting and financial reporting. So making sure it's standardized, that there's supporting documentation, and that there is accurate and timely reporting for management and the board to make decisions. From that work, what we start with is really understanding the current process. So who are the people that are responsible for all the different activities? Where does the data come from? Where does the data go? And what systems are involved in that whole process? So as we work through that and understand the current process, we're identifying all the improvements that can be made to make it more reliable, more accurate, more efficient. I'm going to let Chris come up and talk through some of the improvements we made. Yeah.
Just a point of inquiry on that. Should March, April be 2025 and May, June be 2025?
Should be 25. That is correct.
Okay, I thought it.
Nope, that is accurate.
Hello, everyone. Thanks for having us today. My name is Chris Dixon. I'm a director in our accounting advisory practice, working closely with Hillary on this accounting and financial reporting improvement project. I'd like to think when we talk about this, and what's helpful to put in perspective is I think of the financial statements a bit as our patient, to put it in hospital terms. And it would be very difficult to diagnose a patient if you didn't say and talk about the symptoms. So I thought what would be helpful for the board, and what we talked with Dr. Blackledge about, is presenting some of the symptoms we're seeing in this first month as we started our work on the financial statement and reporting improvements. I want to highlight 4 items on here, although I'm happy to answer questions on others. The first of which is the process of recording invoices. As you can imagine, the hospital has a large volume of vendors that provide services and goods. And one of the things we've noted is that the process for intaking and recording invoices is problematic. There are multiple ways and multiple people performing this, and as a result, there's been situations where there's been duplications of invoices recorded, and even in minor situations, duplications of payments made. The result of this, and as you can imagine, is really a lack of ability to appreciate and understand what the expenses are for the hospital on a monthly basis, and use that in a decision-useful manner to forecast and look forward. Another item I'd like to highlight on this slide is the leased equipment and some observations we made around how the hospital goes about recording leased equipment. I think this one is best illustrated through a specific example. There was an example where there was a lease, a significant lease for a hospital sanitization equipment. That lease was entered into and then 6 months later commenced. And then not for another year to this date has it been actually recorded on the books and records. So these gaps that we're seeing, again, symptoms of underlying problems, are what we're trying to address. 2 more I'll briefly go through is, one is financial controls over the HR and payroll functions. One of the things we've noted is that because of the ability to have clear and transparent input from those functions, there have been gaps whereby there have been employees who have terminated the organization but have still received payment in some situations. Now, again, that has a real business impact, but the bigger point I'm making here for purposes of this presentation is it also has a financial impact, which we need to acknowledge and remediate as well. The final item I'll mention on this slide is inventory management. Well, the hospital in and of itself, to function, needs to have good controls over inventory management, the financial controls over that, and the way inventory gets recorded. Currently is a true-up system whereby at various points in time, the inventory is counted, and then those are recorded into the financials by virtue of a true-up or true-down. This causes volatility month over month and makes it hard to have predictive value when budgeting and forecasting. All the totality of what I've talked about and the other items up on the slide, the main takeaway I'd like the audience to recognize is that without these fundamentals of financial reporting and data integrity in place, it makes it very hard to get very reliable cash forecasting, which is imperative to a hospital for functioning. And then also, of course, as folks are aware in this room, the financial statements, which are audited by your external auditors and are published annually, are reliant on this information as well. So that's really why we're here, and that's what we're meant to address. Before I go to the next slide, I'll pause and see if there are any questions on this slide specifically.
The example that you raised about the lease that's not reflected in the books and records, what's the financial implication of that? I mean, is that just a failure to understand what the lease terms are and when they're up, or like, what is the consequence of that?
Since it's a new lease there and it has not yet been recorded, the financial consequences is missing net assets on the books. So you're missing assets and liabilities, and you're underreporting lease expense during this fiscal year. Luckily, this fiscal year has not closed yet, so there's a chance to remediate, but that's the impact for this year.
So to broaden that a bit, in your experience, how would you characterize the comprehensive look at this from not unusual or fairly routine to OMG?
I would say for a hospital of this size and patient mix, I would say maybe 60% of this is not unusual. And there's certainly every organization, every hospital we worked with, there are items that can improve, and there are items that need to be improved. I would say another 30% is maybe perhaps more unusual in nature. For example, when we talk about the HR and payroll issue of somebody receiving payment after termination, there aren't a lot of instances of those, and I don't want to over concern the audience, but that's unusual to say the least.
How big is that?
As far as number or dollar? Dollar, I believe when we discussed the other day, Dr. Blackledge, that these were in the $100,000 range in total. This isn't much larger than that, I don't believe we discussed. But the other item I'll mention as far as the OMGs, there's a small percentage there, but I don't think that's the totality of what we're discussing. Okay, well, maybe we can move on to, now that we've diagnosed the symptoms, what are the solutions? The KPMG team has been working, and this may be hard to see, but what I'd maybe talk to on this slide is work with Dr. Blackledge and the finance team to identify the points of improvement that we've noted for each of the items I mentioned, as well as other functional areas across the finance organization. Right now, after the first month, we have roughly 80 items that we've identified potential improvements for, as well as for those 80 items, a proposed improvement at this point in time. Now, why I say proposed is because over the next 30 and 60 days, what we're trying to do is go through and at the bottom, though you may not be able to see it, is triage these into low, medium, and high impact areas. High impact are going to have significant financial, cash forecasting, or expense regularity for the hospital, benefits for the hospital, whereas some of the lower impact may be very easy and quick to implement, which is why we also highlighted some quick win items. These in the next 30 days, we believe we can roll out working with the finance team here to make sure that things that we consider low-hanging fruits and maybe are in that 60% of items we've noted at other organizations, we can roll out quickly. And I'll give maybe a specific example to help. Many hospitals, of course, I mentioned, have vendors that they need to accrue for and budget for. It's not unusual to have hospitals do proactive outreach to those vendors. Vendors are always willing to tell you how much you owe them. So it helps with being able to budget and estimate how much expenses per vendor by just doing proactive outreach and being able to record a more accurate expense number each period. That would be a quick win over the next, and actually this week, I should say, that we've been implementing and working with the finance function here. So in totality, well, there are 80 items. We're breaking them into 30, 60, and 90-day sprints that we're going to work towards, and that when we speak to you next, we can report out on how we've worked to remediate some of these. I'll pause on this slide, and before turning back to Hillary, I'll take any further questions. Okay, back to you, Hillary.
Great. So this is where we're at. If we want to go to where we're going, so as Chris mentioned, we have our quick wins we're implementing now. For the June close, we'll be able to see which ones have been implemented, what maybe hasn't been implemented that we thought should be, and what do we know we're going to implement for the next month. So we'll have this tracking mechanism for July as well as August when the team does the July close to see where we're at compared to where we started. At the end of August, we'll essentially hand over an implementation roadmap, which has all the recommendations, what has been implemented, what still needs to be implemented, and how those recommendations fit into the current state process. With that, we know for June, it's fiscal year end, so the annual financial statements and the audit is very important. And we'll be working with the team through that process as well and identify additional implementation or recommendations that we can recommend. Any
A question.
Yeah.
The ultimate goal, one of the goals here is to provide the ability, the information, reporting in a way that is useful to the board, for example, senior leadership, but also this board. Can you provide the board an understanding of how these improvements that you have suggested and that the hospital is going to be implementing, how that can lead to better decision-making by the board? In other words, help us understand how the tools that you're helping put in place are going to be useful and should be utilized by the board in its function.
Yep. I would say two things. Overall, our goal is reliable and timely reporting. And so where that it helps with management's decision-making and the board's decision-making. So when you're getting financial information from Dr. Blackledge and the team, it'll be more reliable. We'll hopefully be able to get it to you sooner without as many revisions or restatements up until the board meeting, so that you have confidence in those numbers the first time they come around.
And one additional question, the 80 or so improvements that are going to be on the timeline that was on the previous slide, is there have you seen in other organizations where you've provided similar recommendations and implementations? What's the best mechanism to ensure accountability that the hospital implements those? Is that a board level function? And if so, how have you seen that done successfully at other organizations?
Yeah, that's a great question. So in other organizations, we've done similar projects where we'll help with implementing the recommendations, but obviously a handful might take longer to implement than our project allows. What we've seen is where it's a management review function to report back to the board of how well things are going. In some cases, we have done a second kind of type project where we come back and re-review in 4, 6, 12 months to see did these implementations stick, just as a third-party advisor as well.
Great, thank you.
Thank you very much for being here. Are there any other questions for the team? And if not, please go enjoy Nashville. And we look forward to the rest of the work you're doing over the next couple of months. Thank you.
I just had a quick comment, and I made this comment in our finance meeting, that I want to applaud leadership for taking a proactive approach and using a medical model, so to speak, to identify what issues are really pretty glaring, but really we didn't know anything about. And I'm saying that very loosely, but in order to address them in a more efficient and effective way. So kudos to that.
Right.
May financials.
Right, and before we just jump into May financials really quick, I want to back up just for a second and talk about the management review function and provide a real-time example. Then we're going to jump to the future with an introduction. But from a management review standpoint, we produce financials around the 10th of the following month. So May, we're produced by June 10th. And from there, we continue our management review function, and we look at things and we ask questions, and particularly myself in the role asking questions. When asking questions, I did not get an answer. I couldn't come back to a number that I was looking for within our financials, and that number was $9 million. And after consistently asking, I recognized through a response from the team member yesterday that we had what I would call a material issue and a material error. And so what you have in your packet is a restated financials. This is a real-time example of why it is so important to have brought KPMG in. A couple of other things that they'll have that will be delivered to us, including standard operating procedures. What does that checklist look like? Did you reconcile the bank statement as you produce the financial statement? These are the things that tick and tie and prevent us from having these gaps. So these are the things that prevent me in my role from having blind spots, right? And I won't talk about that any further. I want to move to the future. So with that, I want to bring up our newest hire as the controller. So Ray Burketto, if he'll come up and join us, he'll talk a little bit about the financials, but I'd love for Ray to talk a little bit about himself. And the financials will be just a highlight, maybe 2 or 3. I recognize timing. And this is the month of May, and we're really heading into a new fiscal year. But I want to welcome Ray to our NGH team. He has 20 plus years of accounting experience, much of it in healthcare with behavioral health background and hospital, financial accounting management background. Ray has served in several executive roles, so we welcome Ray to the team here. Come on, Ray.
Thank you. Hello, everyone. I'm really fortunate to be here today and to start this, new adventure with the finance team. I know there's a lot to do, and Dr. Blackledge and I are on the same page with our approach to how we identify issues, how we analyze them, and come up with solutions. So I think that kind of highlights one of the points that I think needs to be in place here, which is alignment. We need to be alignment in those goals and making sure that we, identify those issues, come up with the solutions, and then implement those solutions. And that comes from the top all the way down. And so specifically with the finance team, we need to make sure we're in alignment with the policies and procedures, the goals of any finance team, which is to produce timely financials. So that, and then also, I don't think, again, I can overstate the importance of having KPMG involved in this process. Otherwise, it's come on in, see what you can figure out, and good luck. And there's some some merit to that, of course, based on experience and knowing what the right way to do things is. And so, but having KPMG come in and be able to come in with with all their resources and experience and expertise, that really helps give us some credibility as a team, as a department, and to come in with that kind of credibility is important and will help us make those decisions. And finally, what keeps ringing in my brain about what's needed here is from the book Good to Great, and it's about discipline. There's lots of things about that book I really enjoy, and it's so applicable to this situation, but it is a culture of discipline. That's what we need. We need disciplined thought. We need disciplined action. We need people that want to do the right thing the right way and be consistent. If we identify a mistake, let's own it, let's correct it, and let's move forward. So I look forward to that. And thank you. Glad to be here. Do we want to look at the financials briefly? Yeah, the income statement. Well, everybody can read that well, I'm sure. But you have that in your packets. Really, I just want to highlight a couple of things, and they're really a lot of what we've already kind of identified. And so looking at the revenues overall and expenses, if you look, you can see the revenues for current month revenues. And again, this is just to give you a flavor of kind of where we're at and where we need to go. Current month revenues are 18.7% under budget overall. That's 16.1% for inpatient and 19.7% for outpatient. That translates to $5.3 million under budget on revenues. And then all the way over to the right, you'll see on year-to-date revenues where we are 11.8% under budget overall. 7.6% inpatient and 13.5% outpatient. And that totals $36.4 million under budget. So you can kind of see where we are, kind of where we need to go. A lot of the things that we're already implementing will help us get there, or designed to help us get there. And then briefly on expenses, looking at total current month expenses, we are 4.6% under or over budget on expenses, or $584,000, which honestly is a better month there. because if you look over to the right on total expenses, you'll see that we're over $14.5 million or 10.3%. And a lot of that is concentrated in salaries, benefits, contract labor, 9.6 million, 2.7 million in physician services, and 3.9 million in leases and utilities. So that's kind of showing you a little snapshot of where we are, a little summary of where we are and where we need to go. And a lot of what we're, like I said, a lot of what we're doing will help us get there. Any questions? Okay, thank you.
Is this budget, is it lagging behind in some of the changes in workforce reduction? Is any of that reflected in these numbers, or will that come out in later months?
Go ahead, take that, yeah. Right.
Great question. Great question. And no, those are not reflected in that numbers. You will see some of that reflected in June, and then there were severance packages associated. So not until we enter into July will you see the total piece removed. I can tell you the sum total of the reductions were about $4 million. So,
I mean, it does look like it's in, when it comes to some of the contract labor, that there's some, it's a very good change.
correct.
In this
Correct.
report.
Now, we move to the contract labor line. I can share with you, contract labor, you should be seeing that reduction because we began that activity probably late February, early March. So somewhere around March. There was reductions and eliminations in our contract labor, in our contract services as well. So you will see the differences flowing through there. The sum total for the reductions in contract labor, contract services were about $6 million. So as time moves, as we close one period of time out, and I'm recognizing 1 month as a period, we have 12 periods. As we close out the period of June, July, and August, you will see that working its way through.
Any further questions from the finance team? If not, we'll move ahead to our, we have 10 contracts to consider. Ms. Smith, if you could summarize as we go.
You want to spend about 30 minutes debating each one?
I'll cut the debate off at 30 seconds.
Understood. Okay, so I will move through these and rely on my esteemed executive leadership team members to help if I get caught up, since some of this is definitely not my area of expertise with subject matter, especially with technology. So we'll start out with UKG Phase 1. And Phase 2, I'll talk about these in generalities, but my understanding is we need to vote on these and approve them individually. So please make sure you ask questions if you have any. So we have been in an outdated technology space with regard to timekeeping, PTO, recruiting, on and off boarding. We've basically had 4 systems in place, and these 2 new contracts will allow us to replace those old systems and go with UKG, which is a product of Kronos. And so this is a great upgrade. The options were UKG and Workday. Workday typically works with a larger company size, and so that's why UKG was selected. Additionally, there was multiple discounts applied, and then also they agreed with delayed vendor payments. So that being said, the first one specifically is with the timekeeping and PTO and accruals. The second one is specifically with the recruiting, on-off boarding, et cetera, as the talent acquisition and benefits. This will streamline a lot of things here, and will also add for mobile ability on the phones for employees. So we will start with UKG Phase 1. Any questions on that or discussion? If not, I'll ask for a motion.
Move.
Is there a second? Second. Any discussion? Okay, all in favor?
Aye.
Motion passes. UKG Phase 2, similar thing. Again, this one is specific to the recruiting on-off boarding. Is there a motion to approve?
Move.
Is there any discussion? All in favor?
Aye.
Okay, MCG, this is a renewal of a contract. There is basically two options available in this renewal contract. This is basically works with the insurance companies, allow clinicals to people that are seen in clinics to basically be transferred to inpatient and then make sure that those are tracked appropriately. This helps with denial prevention. It's basically two options here are basically MCG and the other is Interqual. So one's not better than the other. It's just what we've used and people want to stay with it. So that being said, is there any discussion? Okay, I will entertain a motion to approve. Okay, is there a second? Any Second, okay. Any discussion? All in favor? Motion passes. Okay, next up is, Comcast. So Comcast is basically a redundant internet contract. So it allows for business continuity planning in the event that there is an issue with Lumen, which happens to be Nashville General Hospital's provider. They did go out, they did price, it wasn't an RFP, but they did price 3 different entities. And so annual cost $42,000. This is for, again, the continuity planning. Any questions about the Comcast internet contract? If not, I will ask for an approval of the contract. Is there a second? Any discussion? All in favor? Okay, motion passes. Liquidware Labs. So this is a contract for virtual desktop infrastructure. I had to ask what that actually was. So all the images and kind of the individual laptops and desktops you see, I kind of all roll up to a server is my understanding. And this is a maintenance agreement that allows for servicing of that infrastructure. So any questions or do you need any further discussion on that? Okay. If not, I will ask for a motion to approve the Liquidware Labs contract.
Moved.
Is there a second? All right. Any discussion? All in favor? Aye. Motion passes. The Dell contract. So there's 2 Dell contracts here. One specifically, they're both for licensure, if you will. The first one is for cloud services, which is like Microsoft Cloud, the SharePoint, the other Microsoft Office items that we know about, Excel, PowerPoint, et cetera. The other is basically a license for the desktop and servers specifically. So you have to apparently pay when you buy a piece of equipment. I equated it in the finance committee to PMI until you pay it off, and then the PMI goes away. So basically that's the way it works. Once we pay it off, which they say is 3 years, then we have a significant reduction in the cost, and it goes down to, I think, $66,000 a year instead. So that being said, the first contract, Dell CSP, do I hear a motion to approve? Okay, is there a second? Any discussion? All in favor? Motion passes. Dell MPSA, this is the second contract, again, for the desktop and servers. Do I hear a motion on the floor to pass this contract? All right. Second. Okay, is there any discussion? If not, all in favor? Okay, and Microsoft. Microsoft is let me get to this one. This is a maintenance contract that, hold on just a second, that allows for us to reach in and get exterior support. So this would be a virtual support. We do have people like Adam Burton, who's on Dr. Brown's team and under Melanie, that is, he stated Microsoft and Cisco certified. My question on this was, hey, is this something we can train people up to do so we can get rid of the contract? But it sounds like that there are so many different nuances of Microsoft and the system that we would need some type of virtual relief in case there is a subject matter or specific thing that Adam and his team can't answer. So that is what this contract is for. Is there any question or discussion? Anybody need any more clarification? If not, I will entertain a motion to approve the Microsoft contract. All right, is there a second? Is there any discussion? All in favor? Aye, motion passes. AT&T, this contract simply just allows interconnectivity between all sites. It is an annual cost of $70,000 and term for 3 years. So, anybody have any questions on that one? If not, I'll entertain a motion to approve. Is there a second?
Second.
Okay. Any discussion? All in favor? Aye, motion passes. Lumen, this allows for the, this is an internet between both. It allows for two different SSID, apparently, interfaces. One that allows for the internet with the hospital, and the other allows for those who are visitors like ourselves to come in and use the internet. Annual cost $25,000 a year. Do I hear a motion to approve?
Second.
Is there any discussion? All in favor? Motion passes.
Mr. Chairman?
Yes, sir.
First of all, congratulations to the committee chair for running through these and summarizing them in a fashion that provided a great deal of efficiency for us here and information. So thank you for that. Second, please go ahead.
Welcome.
Okay. Second, related to all of these contracts or individual contracts, do we have an opportunity to negotiate? And at what point does that occur? And, you know, for instance, are we getting contracts that are specific in some of these organizations to hospitals or to government? Do we plead poverty? Do we plead that we want pity contracts because of who we are and what we do and the size that we exist? So I'm just curious as to know whether we're just taking numbers as they're presented to us, or what do we do with that?
I'll mention just a conversation we have, and then obviously Dr. Brown, Dr. Blackledge, that especially since you've put these in front of us, but we have had part of this actually discussion in the meeting, and there are discounts that have been applied, especially in some of these contracts or payment arrangements made that we have asked for. I've challenged the ELT as well to go back and look across all lines and say, as an example with Dell, these are two contracts. Yes, it was the best bid out of the group, but by the way, we may be paying you potentially, who knows, $4 million. What can you do for us? And so I know that there was a conversation about Presidio and the way we were obtaining our hardware, and they had gone back and requested those discounts. So, you know, I would say Dr. Brown and I've had lengthy discussions about that, and I'll let him weigh in.
And while he's coming up, I'd like to say that there are just some real basic things, and since I'm on the finance committee, that I have been learning all along, but there's been much effort to be more transparent in terms of even the forms, and also practicing due diligence in terms of really, because not a lot of time has transferred. I mean, this has been a lot of transformation over a short period of time, but to be very thoughtful about looking at how we can look at looking at other vendors and things of this nature. And so a lot of energy and a lot of thought process, a lot of tough decisions have been made. So I just want to know that this has not gone unseen by the board, but it is a work in progress, and also that they really are, how can I say, they're really being very, they're scrutinizing their own thoughts and really asking hard questions of themselves in order to bring the information back. So thank you.
I would say Ms. Smith and I have talked about that. Are we where we think we should be or could be? I don't think so. But I do know that from just my own experience, like the contracts that I've bought before the board, there's a 60 to 40% savings on like high dollar, like 1.2 billion, the CT scanner that we received. We also negotiated a 2-year maintenance-free contract that calculates to about $140,000. So when we're going to contracts, that happens on the front end when we're dealing with the vendors. I know that Ms. Thomas and I talked this week about contracts and IT contracts. And I shared with Ms. Smith that I've wrote a note in my book where we're going to go through every contract to make sure that those contracts are just not renewable each time that we're actually looking at vendors. When I talked to Melanie today, she's out. But we talked about, we tag on to like state contracts or metro contracts to get the best deal that we can get as far as when those contracts are being renewed and looked at. So we are doing the work up front, and Ms. Smith is definitely holding us accountable before we present those contracts up here. And so we're looking every time that we go out and talk to vendors, so we do plead, beg, and borrow and tell them that, we can't afford a $2.4 million scanner, but we could afford an $800,000 one if they would bring down the price. And normally the vendor works with their finance company to get us to where we need to be at. You're welcome.
So we went through these very quickly and efficiently. Thank you. But I would like to assure everybody that these are gone over in detail in the Finance Committee, presented by the member of the team that knows the facts and represents the topic of that contract, including going over numbers, going over competitive bidding, and so they're very well vetted. And also we've asked Dr. Blackledge to let us know whether these contracts are budgeted or not, and we expect to hear more about that in the future. But she assures us that by and large, all of these contracts are things that we've been doing. Some of them are more expensive this year, some of them are less, but they are budgeted. If there are no more questions about the contracts, next is the board chair's report. And I'd like to tell the board that it has been an honor and a privilege to serve as your vice chair for several years and as your chair for the last several months, particularly in the last several months when it's been a time of change and looking forward. I would like to particularly recognize all the members of the executive leadership team, and in particular Dr. Elders, Blackledge, and Bullock for quickly moving us into a new era. We will look forward to a report from Dr. Elders next month of what has been done in the last several months to reduce expenses and bring the financial house in order. And that's a really important part of what we have been doing in the last few months in conjunction with our consultants. Even getting the house in order, our work is not nearly finished. There's a lot to do, and I look forward to working with this board and the mayor's office in particular to study the healthcare needs of Nashville over the next couple of decades and how Metro Hospital fits into that, to study other public hospitals around the country to determine what approaches are successful in the 21st century, what makes good hospitals work to help us plan, to secure our relationship with Meharry Medical College. We've taken a big step, or will take a big step in the next month to do that, but still a lot of work to do there, including addressing a lease renewal, which is not that far away, and is going to be absolutely necessary given the timeline that we have, and ultimately to explore and make a decision about whether we will be in this building in 5 years or a different one. So we are taking care of some basic things here in the last several months, but there's a whole lot to do, and I have the ultimate confidence in our leadership team and in our new board officers to lead us in the right direction. So thank you for allowing me to be a part of it. And now turn it over to Dr. Bullock, who is our Chief Medical Officer and gets to sit in the CEO seat tonight and give us a report.
Thank you, Dr. Martin. I will be giving Dr. Elder's CEO report. She did prepare this ahead of time, so there are some verbal revisions. You will find this in your board packet. We did have a great turnout at our 17th annual Dr. Hardy Cancer Survivorship that was held on June 1st. Dr. Blackledge spoke to the leadership restructuring that took place on May 30th, estimating a net cost savings of approximately $4.5 million. We did take that leadership position number down from about 117 down to 67 and down to 6 chief level positions. With our efforts to continue to maintain financial stability, we did make a difficult decision to delay any across-the-board salary increases on July 1. A memo was sent to the staff on June 23rd regarding that. We've spoken quite a bit about KPMG. They continue their operational optimization, and we will continue to get updates and reports from them as well. We've also spoken a good bit today about our PSA. Our last full meeting did take place yesterday. We do have a final draft and document available. It is currently going through the final review and revision process by all parties. I thank Christy Lewis for keeping up with all the revisions, all the red lines and multiple pages and multiple people's input. So thank you to Christy and the entire team for working together to get that done. Our target date remains July 2025. With that, we also held new resident orientation yesterday with a luncheon held for them up here. Hopefully they did not interrupt your meeting too much. Metro internal audit. There is still one outstanding compliance item, and that's legal action to recover overpaid funds to City Valet. So still looking to pursue that. Christy Lewis received a quote from Holland and Knight, which requires us to research other firms due to the quoted cost of that. Our current legal representative, Spencer Fain, does have a conflict of interest, so they cannot represent us in this matter. We've also, from Ms. Denson, had a report from the Tennessee Department of Health. We had a basic pediatric emergency care survey, and their only finding was our helipad, which has been out of commission for a number of years, and we have worked to resolve that citation with an alternative plan with Nashville Fire Department. We still have a lot of issues securing capital funds for facility repairs and enhancements. That's very essential to our function and our success forward. So we continue to need support from the Hospital Authority Board to help secure capital funding. And that is the interim CEO's report from Dr. Elders. I will entertain any questions if you have any.
Thank you, Dr. Bullock. And our next meeting is on July 31st. And if there's no further business, I will turn the gavel over to our new chief for adjournment.
Thank you.
Hit it hard. There you go.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.